As far as cancer goes, we take care of rectal cancer and colon cancer. The therapies for both have changed so much in the last 20 years, but I think the most important change that I've seen and the thing that I'm the most excited about is the way we take care of rectal cancer patients. 15 years ago, if you came into my office with a rectal cancer, the answer was almost always the same. We had it one hammer, and that was radiation, and then surgery, and then chemotherapy. And that was the answer for almost every patient. What we've learned over time is that some patients may not need radiation or chemotherapy. Some patients may just need surgery. Some patients we may be able to do just a local excision, removing the tumor from below without any of these other adjuvant treatments. But in some of our patients, and this is the most exciting part, now we can start out with radiation and chemotherapy and potentially avoid surgery altogether. And why that's so important with rectal cancer is because when we take out someone's rectum, sometimes they need a permanent ostomy bag or colostomy. Sometimes removing the rectum has a lot of functional consequences. And if I can avoid doing that to patients, it's very rewarding. And we still can cure their cancer and avoid all of those functional issues and all of the problems with surgery. When somebody comes in with colon cancer or rectal cancer, there's, as I said, maybe 10 years ago, there weren't a lot of options. For each cancer, the approach is a little bit different and the odds are a little bit different. But generally what our job is to present all the information to the patients and then help them make that decision. And a lot of them will say, well, doc, what would you do? And I say, well, if you were my mother or if you were my sister, I would tell you to do this. But everybody's different and everybody has different expectations. And it's my job to try to help decipher what someone's wishes are and what their fear of cancer is and what their fear of complications from surgery or radiation or any of those other things, and then try to put all that together and come up with a treatment plan. So it is always a two-way street for making decisions medically, especially with cancer. Not only in research and in the literature, on the news recently, I mean, you can't hear a story about colorectal cancer and not hear about the way that it's affecting people at younger and younger ages. And nobody really understands the cause of it, whether it's the preservatives that we get in our foods or whether it's pesticides or what. Nobody knows what that answer is, but it's very clear that people are developing colon cancer at a younger age than ever before. In fact, a few years ago, we moved the age for screening colonoscopies from 50 down to 45 because we were seeing so many people in that window who were being diagnosed with colorectal cancer. Anybody who has symptoms should at least talk to their doctor about it because most colon cancers start as colon polyps. And colon polyp is not a cancer, it's just a precancerous growth, and they're very common. About a quarter of the population has them at age 50. If we take them out, we can prevent cancer. By taking out that precancerous polyp and keeping an eye on people's colons, colon cancer is preventable, and it's really the only type of cancer that is truly preventable just by doing your screening and surveillance for it. In addition to that, if you're having symptoms or bleeding or pain, talk to your doctor about it because I've seen colon cancer in people as young as age 13. So there's no age where you say that it cannot be cancer. Granted, it's much more common as you get older, but anybody who has symptoms should obviously at least talk to their doctor about them. And screening is the most important thing. I think that everybody should have colon cancer screening, no matter how afraid they are of a colonoscopy. A colonoscopy's got a bad rap. I don't know how, because it's not that bad of a procedure. The procedure of a colonoscopy is pretty straightforward. You sleep through the whole thing. You wheel into the room, I say hi, we do your procedure, and the next thing you know, you're waking up in the recovery room and it's not painful. But a lot of people just say, I will not have a colonoscopy. And if that's the case, I don't think we should force people into having colonoscopies, but there are other alternatives, and the fecal DNA tests are actually very accurate. They're not perfect, they're not as good as colonoscopies, but they are the next best thing. And for somebody who doesn't have symptoms, who doesn't have a family history of colon cancer or colon polyps, and who is scared of having a colonoscopy, I would much rather you say, I'm happy to do a fecal DNA test, as opposed to just saying, nope, I'm not doing anything about it. Because a fecal DNA test, we catch a lot of cancers that way. We catch a lot of polyps that way too. So it's a very good screening test. As I said, colon cancer is curable if caught early, and it's preventable if you catch it before it even happens by removing the polyps. It is a preventable cancer, and I think that that's the most important thing that I can tell you today. We've done a lot of work with clinical trials here. A lot of them are WashU initiated, and a lot of them are NIH initiated, but we participate in a large consortium, especially with rectal cancer, and that has really allowed us to be at the forefront of this non-operative management of rectal cancer. We've been doing it here as long as anybody in the United States has been doing it, and I feel like we have a real expertise, not just as surgeons, but as radiation oncologists, as medical oncologists, and as our radiologist. And being a part of WashU and Siteman has really allowed us to all work together. We have a quarterly meeting with our folks that treat rectal cancer to talk about the treatments and to talk about how we want to tweak things here and there according to the latest data or according to some of the data that we're seeing in some of our studies. And that's been really rewarding and exciting. And I think we're still changing the future every day here at WashU.